David Stanley is a writer, teacher, actor, and narrator. His book on melanoma, titled Melanoma, It Started with a Freckle, is available on Amazon. David, over to you.
Thank you, Priya. Dr. Fong, a pleasure. Thanks for being with us today. I appreciate it.
Okay. Thank you.
I have a couple questions for you. Priya, if this is the way we're going to do this, I'll ask like my 2 or 3 questions, and we'll move on to the next guest.
Yes.
Okay. So,
yes, David.
In the melanoma community, one of the big issues that a lot of the patients are having with the checkpoint inhibitors like Keytruda and Opdivo are the side effects. And you know that some of them are just so devastating that even though the patients are getting good results from those checkpoint inhibitors, they have to stop treatment. Looking forward, what kinds of things are you thinking about in your lab to help ameliorate some of those horrible side effects that the checkpoint inhibitors kick off?
No, this is a terrific question. This is one of the risks when we turn on the immune system to fight the cancer. We also turn on the immune system that might lead to the immune system attacking some of these other tissues. And within our research program here, we actually are studying this, whereby we're taking blood samples from patients starting with these checkpoint inhibitors, and if they were to develop the toxicities, we'd again get blood samples from them, but also if there's an area that's being involved with this side effect, we actually take a biopsy of that, and in doing so, what we can do is finally dissect out what the immune system is actually seeing in these tissues. At this point in time, we don't actually know that very basic question, and we don't know whether these side effects that we're seeing are the same as diseases that we see. So, for instance, if people develop diarrhea, is this the same as inflammatory bowel disease or colitis, or is this completely different? And so this is a very active area of research at UCSF, and we're really trying to tease this apart, again, trying to learn as much as we can from every person that we treat. The other component is we actually have a team of specialists that deal with these different side effects. This is a really new area in medicine, and so we have specialists that are focused in each organ that these side effects can arise in. And we basically have a referral clinic to help manage these patients. So if you go on to our website, which is immunotherapy.ucsf.edu, there's actually a link there to our specialists who are focused on helping to manage as well as helping to research why these side effects arise.
That's information then that I can take back to the melanoma community and share with them, because it's a big concern. I have 2 more questions, if I could. First of all, I know you do some work with BioAlta, and they're doing some interesting stuff. Could you talk for a little bit about conditionally active biologics? It sounds pretty interesting.
Yeah, so we actually just had a publication on this about a month or 2 ago, and the idea here is when you give an immune checkpoint inhibitor, these antibodies basically go throughout the body. And in fact, when we use radiographic imaging to look at the distribution of these antibodies, they're in the spleen and in the lymph nodes and in the lungs and in the liver. They're all over the place, in addition to being in the tumor. And so the idea is, rather than having these antibodies turn on the immune system everywhere in the body, could we actually direct that to the specific tumor site? And in doing so, could we actually get these to work better? And what we found in preclinical models is indeed you can actually not only maintain anti-tumor responses. So you can basically shrink tumors in these preclinical models. You can actually avoid some of the side effects in these preclinical models. And so, this company, as well as others, are thinking about actually moving those into the clinic and have actually moved them into the clinic. And so that's another area that I would really, suggest staying tuned, in that, if we can really improve that therapeutic index by either maintaining or improving clinical responses, but avoid some of the side effects, that would also represent a significant advance.
Okay, last question. And oddly enough, I'm actually teaching some of this to my high school seniors in biology as we speak. They have a test tomorrow. I'm here in Michigan. I'm a Michigan State grad, and I live in Michigan, and I follow Dr. Newbig's work on the RNA transcription inhibitors. And I know you might not be comfortable talking about somebody else's work, especially so early on, but could you explain it for us a little bit, and then talk about maybe some comparisons between its potential versus some of the work that you're doing in immunotherapy?
Well, our RNA is basically the message with which cells produce proteins and work, and so it basically gives a cell a program on how to work. And as you might imagine, targeting RNAs through different approaches really allow us another way to reprogram a cell. And so if you think about a cell as being, the computer, the RNA, represents the software. And so I think, there are many ways now that people are looking at using RNA so that you can reprogram the cells that can either help to stimulate an immune response, or it could serve as means by which you could actually turn off pathways that you think might be impacting the immune response. And so it's really a wide open field here, and another exciting area that hopefully we'll see developing into therapies that hit the clinic.
Okay. Thank you very much, Dr. Fong. I'm going to pass it along to whoever's next on the panel. I appreciate it.
Thank you, David. Next, we have Joel Nowak. Joel is founder of Cancer ABCs and a survivor of 5 primary cancer. Joel, you're live.
Hello. Yes, I'm here. How are you? Thank you so much, Dr. Fong. We appreciate your presentation. I actually want to do a little bit of a follow-up question to David's excellent question about side effects. Many people have autoimmune illnesses, arthritic conditions, and things of that order. And if you're taking off the brakes of the immune system, isn't that going to create a conflict or a problem for people? Should people with autoimmune illnesses even consider some of these immunologic therapies?
That's also a terrific question. The clinical trials that we perform on folks with these immunotherapies exclude patients with autoimmune disease. And so as a result, information that we have from these clinical trials on autoimmune disease patients is lacking. What's happened as these therapies are now FDA approved is that physicians can now decide how best to use these drugs and whether or not trying these treatments in folks with autoimmune disease might be appropriate. This is something that is really evolving now, and it is evolving in medical practice. And I think it's critically important for patients to really consult with their physicians to see whether or not it would be appropriate, because the concern is that by removing the brakes, you would potentially make the autoimmune disease worse. Now, if an individual has a distant history of autoimmune disease that is not active, that might be a different scenario than somebody who has active autoimmune disease at the time that they also need their immunotherapy. But I think, this is really a critical question that individuals need to take up with their physicians on a case-by-case basis, because, again, we don't have a lot of experience based on the clinical trials done thus far.
Right. Thank you. And just to make sure it's clear, and I think you said it, but still, that if anyone does have an autoimmune illness or is concerned about that, they need to really make sure that their doctor knows about that, and that enters into the conversation. Also, if I would ask you if you could clarify something. Oftentimes I find when I talk to patients, there's some confusion under the concept or the word vaccine when it comes to immunologic therapy. Most of us, or many of us, think of vaccines as something that'll stop a disease, but you mentioned that Staphylococcus T is a vaccine, but it's only given to men who already have prostate cancer. Could you clarify that a little, please?
Yeah, so most of the vaccines that we use in medicine are prevention vaccines. And so, the pediatric vaccines for measles, as an example, these aren't to treat measles. It's actually to prevent individuals from getting that infection. And so, in the context of cancer, we have not gotten to that point of giving an immunotherapy that's targeting the cancer to prevent the development of cancer. There are some vaccines targeting viruses such as the hepatitis virus as well as human papillomavirus. People who have chronic infections with those viruses are susceptible to liver cancer, to cervical cancer, and we have those infectious disease vaccines, but we really don't have a cancer vaccine now that targets the actual cancer cells before a patient develops it. And so this is where the Sipuleucel T that we talked about, that is a vaccine, but in this context, we're using it not to prevent prostate cancer, but to actually treat the prostate cancer. And as you might imagine, administering a vaccine when a person already has the disease may be a bit more challenging. And so this is why that vaccine is being studied in combination with other immunotherapies, but also new vaccines are being studied that are also trying to trigger immune responses. I think the other element is, rather than giving these immunotherapies to people with metastatic cancer, that we should actually administer these vaccines earlier to people with more limited disease. And so, in fact, that's what's going on now with Sipuleucel T, where men with localized prostate cancer are getting that vaccination as part of a clinical trial. But I think, this is something that hopefully as vaccines gain more traction, we'll see them being studied in earlier states of disease.
Thank you so much. Priya, I think I'll go ahead and let somebody else jump in at this point. Thank you so much for your answers.
Okay, thank you.
Next to the panel is Amy Marash. Amy is a stage 4 colon cancer survivor and a retired TV camera woman. Her book of full-color cartoons and drawings about her cancer experience, titled Cancer is So Funny, is available on Amazon. So, Amy, you're live. Please ask your questions.
Hi, yes, thank you very much. And Dr. Fong, thank you so much for coming on the show. And I'm really sorry the new therapies came too late for your father, but I'm glad you're working on them. I guess I'm particularly interested in the patient experience and the caregiver experience. And so, you said right at the outset, this has been a very wild ride. And I assume you mean not only for clinicians, but for patients and families. But I'd just like to offer, from my perspective, I was recruited for clinical trials quite a while ago, in 2009, when I had active cancer, and 2010 when I was in remission. But at the time, I was so overwhelmed by my cancer diagnosis that I really did not understand the trial. And I know how to read. I'm not a real good listener, but I absolutely didn't even realize till I was halfway through the trial that I might be receiving a placebo in my particular trial. And I'm sure it was explained to me, but I didn't know it. And so I guess what I'd like to ask you is what kind of support do you give your patients who are considering entering a clinical trial about the risks or costs and benefits of participating, and do they have a patient advocate or someone to help them choose, should they have treatment when the success rate is, small? Should they travel for treatment? And, personally, I know they told me that my experimental drug probably wouldn't benefit me, but, I didn't believe that. And so what do you do? Is there any independent person who would help a cancer patient in evaluating, is this trial for me?
That's also a really great question, and you're absolutely right. When I talk with our fellows in the clinic as we go in to talk with a patient, I tell our fellows that the patients are really gonna remember, if you're lucky, a third of what we're actually going to talk about. And so this is critically important to repeating critical points, including, if it's related to a clinical trial, but really spending the time to make sure that questions are answered. And so within our cancer immunotherapy team, it's not just an individual physician that would be interacting with the patient. It's really a team that includes a research coordinator, a research nurse practitioner, navigators within the clinic to help with all the different processes and things to consider on the clinical trials, including financial implications. With regards to, having advocates, I think that's a really great idea. At UCSF, what we do have are support groups where, people from the community basically participate and share their experiences, and that sometimes is a forum where people can present the different options. But I think, the critical part is, when we convey all this information, again, we need to really take the time and really need to emphasize, those critical elements that you highlight. And, this is something that, especially with the complexity of these immunotherapies, we're really giving people we're caring for, a crash course in immunology in addition to everything else. And so it's really making sure that everybody is aware of what we're doing and what the risks are. And so I hope that answers your question.
Yeah, it's a great. I appreciate it. I would add to that. I love that you said, they remember a third. I never batted that high. Even when I go for checkups, I don't bat that high. But, it's a great start. And I did work in a cancer center for about 4 years doing arts and medicine. And I found that, and this is, an NIH majorly funded cancer center, that many of the patients had talked to, the navigator or the social worker on their first day of diagnosis or their first day of infusion or whatever. And then when they kind of got their heads together and got sort of used to dealing with their situation, there was no, many weeks later, then, their consciousness would come awake and that have some questions. So, I think maybe, if you think of a cancer center as a money-making enterprise, how much money is going to go into the patient experience? I mean, I know that's not up to you, that's up to administrators, and I appreciate your efforts in educating people. And you're right, for my cancer was colon cancer, and there's a phenomenal forum called Colon Club that you can go online and listen and read, and you can log in and register. You can just read around on that site, and there's a lot of very, very, very informed, I don't know what you call them, posts or threads about immunotherapy. Anyhow, I think that was more or less, let me see what I wanted to ask.
So Amy,
yes.
Amy, to your point, about the patient's experience, one of the things at UCSF is we have a new cancer clinic building that is opening in the next few months, and from the get-go, that building was purpose-built really around the patient experience, exactly as you're describing, and as you know, for folks that are receiving cancer care, you spend a lot of time within a clinic receiving treatments or waiting, and part of that building and a lot of the space is dedicated for patients so that they can spend their time either learning about their disease or learning about new treatments, or spending their time in other ways that they choose. But I think your point about focusing on what people experience is really a critical one, and I think certainly the cancer centers are changing that way, and at UCSF this new building is really with that in mind.
That is great to hear. That is really great to hear, and I appreciate that. I guess for you, I would ask what the challenge would be when you don't actually know the risks. In other words, you maybe would try one of these immunotherapies with a patient that looks like it might be helpful, and then, maybe do you have enough data to even be able to tell someone? And, I know it's very individual, but, this sort of, your mileage may vary, well, this might work for you, but it might immediately do that to you, or 2 years down the road it might do some other thing.
Yeah, these are all things that when people come to learn about the clinical trials we offer, we try to do the best we can in informing folks of the risks. But as you point out, sometimes this is the first time a treatment's actually gone into a person, and in those situations, we try to use the science and the preclinical data to give us a sense of the potential risks that are there. But everybody who goes on to the trials has to understand that there's going to be unknowns as part of the trial. That's the very nature of the clinical trial, and this is where having our team be hyper vigilant for things that are out of the ordinary is critically important, in that we might recognize a new side effect, and that's something that we need to be very vigilant about.